Hello everyone and welcome to the today's topic on extrapyramidal tracts. This is your friend Dr. Devesh Bhatt and this is part 9 of episode 11 on the extrapyramidal tracts. So let's get this started. So the function of this tract is to help you with the involuntary movement of the body, the balance and the posture of the body and coordinating those movements. The example of those tracts, the name of those tracts are the reticulospinal tract. It will give motor innervation to the extensor group of muscle, help you keep your posture all right. Then comes the tectospinal. It will help you with your head movement in the response to your auditory or visual stimulus. Then comes the vestibulospinal tract. It will also give motor innervation to the extensor group of muscle, helps you keep your balance all right. Then comes your rubrospinal tract, and it is known as rubro because it originates from the red nucleus and it will give flexor innervation to the group, helps you keep your balance all right. And then comes the oliviospinal tract, which is responsible for your motor learning and the coordination of the muscles. So whenever there is a damage to the pathway in one of those tracts, they will lead to symptoms like rigidity, which is increased muscle tone, bradykinesia, which is slowness of the movement, tremors, postural instability, and this group of symptoms are known as the extrapyramidal symptoms. So in condition like Parkinson disease, where there is decreased dopamine secretion in the nigrostriatal pathway, there is basically an imbalance between the dopamine and acetylcholine affecting these pathways. Hence, it will cause these extrapyramidal symptoms. In drugs like typical antipsychotics like haloperidol, they also act as dopamine antagonists, hence causing extrapyramidal symptoms. And antiemetics like metoclopramide, which acts on the CTZ center of the brainstem, they will also act as dopamine antagonists, causing these extrapyramidal side effects. Let's study the decorticate lesion and the decerebrate lesion. So in the last part, we discussed that the corticospinal tract was originating from your cortex descending downwards. So if we have any lesion which is just below your cortex, also known as the decorticate lesion, we will have injury of your corticospinal tract. And the function of corticospinal tract is to modulate the balance by inhibiting your extrapyramidal tracts like your rubrospinal tract and vestibulospinal tract. Corticospinal tract will give inhibition to your rubrospinal tract and the vestibulospinal tract. So if your corticospinal tract is injured, it won't be able to inhibit your rubrospinal tract and your vestibulospinal tract, and the functions of those will dominate. So what are the functions of rubrospinal tract? The function of rubrospinal tract is to give motor innervation to the flexor group of the muscles, predominantly in the upper limb more than the lower limb. And what is the function of your vestibulospinal tract and the reticulospinal tract? Their functions is to give motor innervation of the to the extensor compartment of the muscles, predominantly in the lower limb as compared to the upper limb. Now because your corticospinal tract is injured, these actions will overpower and will dominate. So now because of the dominant action of your rubrospinal tract, your upper limb will be in the flexion position, and your lower limb, because of the effect of your vestibular and the reticulospinal tract, your lower limb will be in the extensor position, and this position is known as your decorticate posturing. So now let's look at the decerebrate lesion. So if we have an injury just over here in the lower midbrain, if we have an injury in the lower midbrain, what happens is we have our corticospinal tract which is injured, but also rubrospinal tract is also injured here. And what was the function of rubrospinal tract? It was giving flexor, it was giving motor innervation to the flexor compartment of the upper limb. So now because corticospinal tract is not there to inhibit your vestibulospinal tract, rubrospinal tract is also not there to flex your arms. So what will overpower? Your vestibulospinal tract will overpower, and it will cause extension of your upper limb as well as your extension of your lower limb, and this posture is known as your decerebrate posture. And if you observe and if you compare, decorticate posture is less severe than decerebrate posture, and that's why in GCS, if you observe under the motor category, decorticate posture is given as number 3 and decerebrate posture is given as number 2. So if you observe any patient and if he is in decorticate posture and his posture changes from decorticate to decerebrate, it indicates that the brain injury is getting severe, the intracranial pressure is getting severe, and you need an urgent intervention to save the patient. Thank you so much.